Hi, everybody. Had to update my browser, all kinds of interesting things that Facebook threw at me this morning. Took me 18 minutes to get that done, but here we are. Thanks for joining me. Got some very interesting information that we're going to talk about today. And of course, glad to answer questions. The first thing I'd like to talk about is this whole notion of immunity. I mean, really, that's the whole game. I'm going to post my first link now. And let me know if you would, whoever wants to, if audio and video are working. Facebook Live has been challenging. So we have to talk about immunity. The real question is, let's say you have had this infection. Are you now immune? You're cool to go outside and interact with people, go back to work, teach children all the things, work in a nursing home. Is that really what we should expect from the so-called immunity that we might get if we have in fact gone through coronavirus, confirmed case, etc. So this is the big question on everyone's minds right now. And I would say that The Lancet is one of the most well-respected peer-reviewed medical journals on the planet. They just published the link that I just sent you. The article is entitled, "What Policymakers Need to Know About COVID-19 Protective Immunity." Policymakers like governments, people who are involved in making the rules, what they should know about the so-called protective immunity that we might get or we might not get. We know that about a third of our planet is under some form of lockdown right now, and that reemergence is something that's already beginning. We're certainly seeing it here in America, Switzerland, Denmark, certainly Wuhan. So people are starting to come out. Is that a wise thing or not? Well, the idea is there enough immunity around now that it makes sense to do that? In other words, we're trying to look at weighing the socioeconomic costs versus the costs of having this disease spread. That's the real balance. That's the real question. It's the reason we're chatting on a Saturday morning to look at how we determine what we should be doing. And I think the biggest question everyone has on the planet has to do with immunity. And I'm going to do my best to report what our current status is. So as this article talks about the so-called linchpin, the key factors that we need to think about have to do with increased testing, finding out who does have antibodies, continue our efforts to trace individuals' contacts who are testing positive, looking at the idea of return to work permits. In other words, issuing people a permit because now they have tested with antibodies, if that means that they are immune. So permits based on immune status, looking at repurposing old, formerly used therapeutics, and of course, the idea of vaccination, giving somebody a treatment that would then impart on that person immunity. Now, whenever I say the word vaccination, the comment section lights up. So I'm just going to say, I'm quoting from the article, and I know everybody has views on vaccination, and I'm willing to listen to, many sides of this discussion, but I'm simply going to tell you what the Lancet article is telling us about the notion of immunity. So the idea is that we need to determine who is immune, and we need to define what immunity actually means. And this is in the context of the broader term herd immunity. How many people have immunity, and how does that translate to immunity in our communities, in our states, in our country, on the planet? And how does that inform our ability to get back out and do the things that were part of our lives until really quite recently? So we know that studies are demonstrating that about 10 to 20% of people who have had confirmed infection have little or no detectable antibody. 10 to 20% of people who have symptomatic infection have little or no protective antibody. Now, what does that mean? What is this low antibody titer? What does it mean? Does it mean that they're at risk of a more serious infection or having a mild infection? We don't know. They didn't mount an antibody response. Is that a good thing or a bad thing? We really don't know. We know that in SARS, for example, that the survivors of SARS, a far more lethal condition, about 90% of these people had functioning antibodies that gave them immunity. So these ideas bolster the idea that most survivors of severe COVID-19 would be expected to have protective antibodies. I want you all to think about that, because what I'm saying is this literature is telling us that you're more likely to get higher levels of protective antibodies if you have had severe disease. If you've had mild disease, at least these researchers believe, your likelihood of getting protection moving forward may not be as great. So you may not be as protected, according to these researchers, if you had mild disease. Now, if you have the antibodies, the real question is, how long will it last? But I want you to understand that the people who get severe disease, COVID-19, the ones who are hospitalized, are then far more likely to develop antibodies and be immune moving forward, as opposed to those who have not been hospitalized. Now, that's a new take. I don't think everyone has heard about that. Maybe some of you have, but I was very interested to see this information, that there's a relationship between your degree of perhaps immunity and the severity of your disease. Yowzer, that's something to think about. So again, let's get to this question of how long, if you have immunity, is it supposed to last? And we know that, again, hospitalization seems to be an indicator that you're going to have better immunity. Most of the previous research indicates, in looking at other viruses, that we should expect from this go around with coronavirus to have around 1 year of immunity. We know that having T lymphocyte, I'll explain this in just a moment, immunity against MERS was 4 years. Now that is a different kind of immunity. Two kinds of immunity that we hold on to moving forward. One is our production of antibodies, these proteins that float around and neutralize viruses and bacteria. And the other is a cell-mediated type of immunity, whereby T cells, a type of white blood cell, is able to actually attack viruses, attack the bacteria, and then secrete various chemicals, like free radicals, I might add, and certainly cytokines, that then neutralize that invading organism. So we have two types of immunity here that we're talking about. So we know, again, that if you're hospitalized, about 90% of people develop antibodies within the first 2 weeks of being symptomatic, and that when you get antibodies, it correlates with disappearance of the virus. So they're following these patients, suddenly, bingo, their antibodies go up, and that's the exact time, mostly, that the virus goes down. So it looks as if there's a relationship there, a temporal relationship, whereby the antibodies are getting rid of the virus, as we would expect, as we would hope. So interesting things. So their conclusion is, it seems likely that natural exposure during this pandemic, getting the infection, might in the short term to medium term not give us the required level of herd immunity, and therefore they're calling for an aggressive vaccination program. I'll leave that. You guys can talk about that all you like, because I know that always raises a lot of concern. Now, let's move on to our next topic, and that is, I think, very, very important. I'm going to post this next link. Please go to drperlmutter.com and read these interesting articles. This next study that I want to talk about is really interesting. I mean, there's been some discussion that this virus is mutating. That's our topic. And this study that I just posted from peer-reviewed medical journal, once again, looked at 7,666 analyses of the virus's genome. And they have found not one or two mutations have taken place, but 198 mutations of this virus are now recorded. Now, we spoke several weeks ago about sudden onset of different symptoms in various places around the world. I quoted to you a study out of Chile that looked at how they were really seeing a lot of abdominal, gastrointestinal kinds of things happening and neurological things. I've discussed with you the New England Journal of Medicine article that found about a third of people discharged from the ICU had neurological issues from this virus. So 198 mutations have been characterized so far. That's pretty incredible. Turns out that's not unusual. Turns out that's what these RNA viruses seem to do. And this study indicates that nearly 80% of these mutations were recurrent. In other words, it mutates to a certain level, then mutates back to the original, then back to the, it repeats itself about 80% of the time, but that 20% of these mutations may be new. Now, why does it matter to us? It matters to us because this virus could mutate and become more aggressive. It could have worse symptoms. It could spread more aggressively, or just the opposite. Don't know. But it also, the mutations of this virus has significant implications in terms of developing a vaccine, and also in terms of our ability to keep immunity if we've had the virus and now we think we're okay. If this virus mutates significantly enough, then our level of immunity might not be as significant if there's been a dramatic mutation. 198 mutations have occurred thus far. Take a look at that article because I think it is, it's interesting. Now, before I get to our final article, I want to, which comes from the BMJ, it has to do with what do we do with people in our homes? I think it's a good question because our loved ones might be sick and we might need to care for them. That happens, or who knows who might end up in our home, suddenly get sick even while they're here. And now what do? You don't put them out on the street. You're going to have to take care of people. That's what you do. The question is, how do you do that? I want to talk about that. But before we get there, I just want to say that there is more and more stuff out there that people are sending me about where the virus was created and what's behind it all. And, I think that might be interesting, but it's not interesting so much for me. I'm interested in the medical scientific side of all of this. And most importantly, getting the best information that I can get and then giving it out to you and let you guys figure out if it's valuable or not, and then to make decisions. Having said that, I think this next bit of information is really valuable because it deals with what should we do now that somebody's in our home and they're sick. Obviously, we're going to want to isolate them. I'm going to post a link for you now. And okay, please take a look at this. The study in BMJ, peer-reviewed journal, is called Reducing Risks from Coronavirus Transmission in the Home. The role of viral load. Now, this is really interesting. The role of viral load, what does it mean? Well, it seems clear as it relates to this and other viral and even bacterial infections that the amount of exposure we get is related to the severity of disease that we get. Being with somebody in a confined place for an extended period of time will give you a larger exposure to the virus, a larger viral load, and it looks as if that is correlated with more severe disease. This is the explanation as to why healthcare providers are having such severe disease. And we learned that early on in the Wuhan experience, that healthcare providers were having severe problems, some of whom were dying. And so it really relates to the dosage that we get, as opposed to perhaps picking something up by being near somebody for a few moments, or by having something on our hands, touching our faces, which can transmit the virus, but as opposed to being in a car with a driver for an extended period of time with that person being sick. So understand that most people with COVID-19 are not in the hospital. Most people are cared for at home. And this increases the likelihood of exposure for the rest of the people in the household. Now, people have varying degrees based on what their living arrangements are, varying degrees of ability to isolate individuals from them. So this is, it represents a significant amount of risk. So again, healthcare providers have a bigger risk because it's not just that they're exposed to COVID-19 virus, but they are exposed repeatedly and over long periods of time. So the size of this inoculation, of this exposure, is really critical. Again, passing somebody on the street, inhaling some of the virus might not even cause disease, but it's a bigger exposure. And the problem is that this COVID-19, as opposed to, for example, the flu, has a long incubation time, what we call and a high pre-symptomatic infectivity. I mean, there's a lot of time when people have now got the virus and don't show symptoms, and they might be in your home. They might be your children. I mean, who might they be? And this is one of the stealthy things, sinister things about this virus, that it was one of the mutations that seems to help it spread. So that mutation gets passed on. So the highest viral load in terms of people being infective towards you if you're not infected, the highest viral load takes place just before people start getting symptoms. So just before that friend or family member, whomever is staying with you at your house, just before they start to get a headache and a fever and a dry cough and lose their sense of taste and smell, have some numbness, have abdominal pain, have diarrhea, all of these new symptoms that we're hearing about, just before those symptoms appear, we believe, or according to this study, that's when 44% of the transmissions occur right then. So again, it's something that this virus has created or mutated to that seems to be effective in letting it spread, which is what it does, what it wants to do, right? It wants to spread around the world. And it's one of the stealthy, unfortunate things that it has, I hate to say learned how to do, but it's added it to its repertoire to allow it to spread even further. And again, understand, as I spoke to you earlier about this morning, that it's constantly mutating, 198 mutations thus far. And sometimes that mutation affects the symptoms that we see, like these new symptoms among very young children, where they develop a strawberry tongue. A tongue looks like a strawberry. They get this rash. They can go downhill very, very quickly, looking like what we call Kawasaki syndrome, which is something we all learned about back in the day. And so it looks a lot like that. That's sort of a new thing. The neurologic issues were a relatively new thing. The stroke, the heart attacks, the damage to the heart muscle, all that was part of this virus's mutation over time. So very interesting. So we have to understand that while we are doing our best to avoid contact, we should also be thinking about avoiding the viral load, the amount of exposure that we might be getting at any given time. And this is something we definitely have to be thinking about when somebody is in our home who is sick. So we know that this viral load effect is certainly something that is clearly demonstrated in animals. In the mouse model of SARS-CoV-1, not CoV-2, it's clearly been demonstrated. And now we recognize that this is likely occurring in SARS-CoV-2. We definitely saw a dose response in 2003 with SARS, the original SARS, that the more you're exposed to, the greater was your risk for worsening disease. So that's something to think about. So the authors of this study have created a website. Now this website, germdefense.org, I'll just send you a link, or somebody else can do that perhaps. Here we go, I'll post it myself. This is, I've been there, looked at it. This was originally created as to deal with influenza. And again, but it's really good because it talks to us about how homes can become contaminated, why we have to limit where those individuals go in our homes. We need to understand that bathrooms, if a bathroom is shared, that's a huge source of infection for other people. The virus can be excreted through stool. And so the sink, the toilet, I know it's something you don't want to talk about, but I have to talk about it. These can be powerful sources of vector transmission of this virus. Very important to know that. So in an ideal world, that person's going to be in his or her room. Hey, they can go outside, let them go out. They handle the doorknob, you have to wipe it off. They go outside, let them walk around if they're feeling well enough to do that. They come back in, sterilize the doorknob, then they can go back into their room and open the window. I would suggest that if you have the opportunity to shut that person's air conditioner off, if it's not too warm, that would be a good idea so that you don't recirculate air from that person's room, if that's at all possible. So we have an interesting poem I'm going to read today in a minute called Good Timber by Douglas Mallock. But before that, prior to that, let's look at some of your questions. I see there are about 1,000 of you on the Saturday morning. Let me just give you two other updates, anyone who's interested. The garden is doing great. I told you last time I wasn't seeing tomatoes and I wasn't seeing string beans. Well, they all of a sudden decided to come out. I don't know if it was the coffee grounds. I don't know if it was the eggshells that everybody was telling me to do. But now I've counted 40, not that I'm counting, but I counted 45 tomatoes getting ready to ripen. And I'll probably take you guys on a tour of that soon, and string beans and eggplants. So I'm really very excited. And to the question asking me about the guitar, the newest thing for me is using, very few of you are going to get this, so I'm just going to say Ernie Ball Super Slinky strings on the electric. Anyway, I just thought I would say that. Let's take some interesting questions here, and ready, here we go. Sounds like I'm in with Bill Gates. I'm really hopeful we don't need to go to places like that. That's not what we're talking about here. I don't want to embrace these ideas of conspiracy about who may or may not have done such a thing. I mean, it's not helpful to me. I'm so stupid that I can't understand those videos, so I decide not to watch them. Okay, here we go. La-di-da. Anything else good? I've been caring for my positive grandma in her home for 4 weeks. Okay, likely, it'd be good to have positive grandma checked to see where she is in terms of immunity. Might be something to look at, and also see that she tests negative for the virus. Okay. Okay. I am right because the level of gravity was not justification for hospital. It could be relative to the producing higher immunity. Okay. Where is the link about viral load? Did I not post that? My goodness. Let me see. Hang on. Sorry, folks. Reducing risks? No. Emergence genomic diversity? No. Oh, I'll post it. I'll post it later on. You know what? It's already on I'm sorry, folks. Go to drperlmutter.com. I think it's the third one down. It was just posted yesterday, so you'll find it there. I stay in or go for a ride. I have low immune system. Yeah, it's a great point. I want to go there right now because things are not better than they were. We're all trying to think that things are better than they were, but you know what? They're not. Look at the number of people who are testing positive, but more importantly, look at the death rate. It's still very high and climbing. So we're all tired of this. We really want our lives to get back to the way they were, but don't let up. Now is not the time to say, I'm just going out and come what may. It's a bad virus. It looks like it might be getting worse. Who knows? But it's not time. We made decisions before. Those were the right decisions. We've got to stay with our plan. If we fail to plan, we're planning to fail, and let's not fail. So let's stay with the plan. Let's do what we can to wash our hands, to isolate, socially distance. And I look around my town and I can tell you that without a doubt, in Southwest Florida, people are saying the heck with it. We're going out and not distancing in restaurants, sitting back to back in restaurants with waiters that may not be wearing masks. That would be great if that was reality. It isn't what's going on. We haven't gotten through this yet. Hopefully we will, but we got to toe the line or not. I mean, my sense is that most of you watch these podcasts because you're concerned about what in the heck is going on and you want to stay healthy. That's my goal. It's why we talk about immune boosting. I got a great empowering neurologist tomorrow talking with a doctor about genetics, but also about things like sambucus and andrographis to boost your antiviral immunity. We'll post that tomorrow. The empowering neurologist, please take a look at that. Dr. Sharon Hausman-Cohen, going to be very interesting. Oh, goodness, things are going so quickly here. Stand by. Oh, okay. Have you looked at tocilizumab for patients that are beginning to worsen? Congrats on your garden. Vicki Rogers. Yes, we've talked about that. Anything that ends in MAB, like tocilizumab, is what we call a monoclonal antibody. All these things you see advertised on TV for arthritis, psoriatic arthritis, and all the things that we all think we need to take, all of the generic names that have MAB at the end, that means monoclonal antibody. Now, this particular one is a way of, we know that in things like rheumatoid arthritis, for example, we have an increase in a cytokine, IL-6, and that cytokine is an inflammatory chemical that is quite active in rheumatoid arthritis. So they create these monoclonal antibodies to either attack the cytokine, block it, if you will, IL-6, or block the receptor where the IL-6 binds and does its dirty work. So there's been some discussion, well, why don't we use that now in hopes of reducing the so-called cytokine storm that can be a lethal event when people are in the hospital with COVID-19. That's why this individual asked the question. Now it's been studied, and it looks like it was not effective. So great question. We talked about that before the study was published, saying, hey, wouldn't that be cool if they had a drug that could block the IL-6, maybe cytokine storm, then it wouldn't happen. Been tried in the hospital, in the ICU. Unfortunately, didn't work. Okay. Let's collectively believe the virus will disappear or lose its power. Hey, I'm all in for that. But interestingly, it's been said that hope is not a strategy. I'm all in for hope, but at the same time, we got to do things. We got to actually be proactive and be engaged. Oh, good, Matt Stanton, you get a prize. He just published the link. Thank you, Matt. I suspect to the article that I forgot to post. Sorry. Okay. Any more info about blood types? Don't have any more info about it, but we do see that type A seems to be having the worst experience with COVID-19 as opposed to type O. Okay, should we throw out our shopping bags away and wash everything we buy? I don't think you have to throw away your shopping bags. Now let's talk plastic versus paper. I think you can keep them both. I don't know why you want to, but if you leave things outside for a few days, I think they're going to be fine. If you spray plastic bags with something, be it Clorox or Lysol, I think that's okay. But I wouldn't be bringing the shopping bags into your house right away. We take our shopping bags from the car, dump everything out in the driveway, and then we put the shopping bags away and leave them if we want them. And then in the driveway, if things are in a package, I wipe them down with a Clorox wipe. You don't have to have a Clorox wipe. Soap and water works fine. And then we wash our vegetables in soap and water. I have a great big bucket. I put in some good natural soap, not a lot, and then tomatoes and cucumbers and even, yes, bananas and onions all go into a bucket of soapy water. Take them out in the driveway, hose it all off, then dunk them in some good fresh water. Then they dry and they go into the house. Now, there are sites that are telling us that is not necessary. Okay, it makes me comfortable, and it's, what can I say? I don't know that if that shelf was stocked this morning by somebody who is sick and who may have coughed into his or her hand and then put that food on the shelf, I don't know that couldn't be worrisome, isn't worrisome, and I am doing what I can. So that's what we do. Of course, everybody has their level of being involved with this. Some people have said, well, Dr. Perlmutter, you sound like you're germophobic. And you know what my answer is to that? You bet I am a germaphobe when it comes to this virus. I don't want to get it. I really don't want to get it. We recently learned that Now, patients in the intensive care unit, a big study came out of the Journal of the American Medical Association that 3.1% of people in the ICU are now requiring dialysis. Their kidneys turn off. So they need a dialysis machine, and not just a ventilator now, it's dialysis that has to happen with the whole dialysis team. So I don't, whatever. You can say what you want. That's how we are handling it. I just want to do everything I possibly can. Okay. Yes, right, exactly. People who are sick may be stocking our shelves. Yes, but here's the point. Can't blame them. They may not know. As many as 50 to 70% of people can be asymptomatic, or at least pre-symptomatic, are already shedding virus like we talked about earlier, and just haven't gotten sick yet. And they're at work and they're putting stuff on the shelf. You gotta, my opinion, you gotta do what I think is important. At least we do. Okay. So there is a lot of talk about nitric oxide in how the virus is able to enter the cell and replicate, and ways of increasing nitric oxide are being talked about in online, etc. Various arginine-based products. There was some discussion about Viagra, because Viagra might increase inducible nitric oxide, and that might be something helpful. In fact, I believe there was actually one study looking at Viagra as a preventive or a way of reducing the viral load, etc. And I've not seen anything too compelling about that. So I wouldn't, just keep that in mind. There's a lot of people trying to sell products and talk about, precursors to nitric oxide being arginine. So not a heck of a lot of data there. We're seeing things every day. People are talking about one thing or another. I will tell you, I am very taken by the science that we will review tomorrow on the Empowering Neurologist. We actually have a little slide presentation. We've recorded it already. I'd like you to watch that on Sambucus and andrographis. Anyway, Sambucus and andrographis. Please, somebody do a little, just type that in on the text. All right, I'll take a couple more questions. Then I have I think a nice poem for you all today. Not I think I have. I know I have it. I think it's nice. Comments here about NRF2. Now, NRF2 is something that I'm very taken that so many of you know about. And interesting, the post right above it says garlic, cloves, and onions are good, and that they work by activating this NRF2 pathway. NRF2. November, Romeo, Foxtrot 2. And this is a master pathway for antioxidants, for reducing inflammation, and for turning on our detoxification pathways, activating something called glutathione. And how do we jump into this NRF2 pathway and light it up so that we can balance our immune systems, balance inflammation, etc.? We do so with lifestyle choices. For example, the foods we eat, the cruciferous vegetables, broccoli sprouts, that will help us raise our sulforaphane levels. We'll jump into this NRF2 pathway. NRF2, look it up. It's really interesting. Coffee, yippee, I feel validated. And even aerobic exercise. All of these things activate NRF2. So to answer all those questions, but really look into, I think on drpromoter.com, we talk quite a bit about the NRF2 pathway. I'll take one last question, and la-di-da. Okay. NRF2 is another question. All right, let me, okay. All right, stand by, everybody. Let me just shift gears here for you, and first say thanks for paying attention today. I'm going to leave you with a poem, and it's called Good Timber by Douglas Malloch. And it talks about being stronger after we are challenged, about what happens to us when everything isn't necessarily going right. Here we go. The tree that never had to fight for sun and sky and air and light, but stood out in open plain and always got its share of rain. Never became a forest king, but lived and died a scrubby thing. The man who never had to toil to gain and farm his patch of soil, who never had to win his share of sun and sky and light and air, never became a manly man, but lived and died as he began. Good timber does not grow with ease. The stronger the wind, the stronger the trees. The further sky, the greater length, the more the storm, the more the strength. By sun and cold, by rain and snow, in trees and men, good timbers grow. Where thickest lies the forest growth, we find the patriarchs of both. And they hold counsel with the stars, whose broken branches show the scars of many winds and much of strife. This is the common law of life. So it makes us more resilient to have challenges. Maybe that's an upside, who knows? I want to say to everybody, thank you for spending some time with me this morning, Saturday morning. And I will probably do an update from out in the garden at some point. I got a lot of positive responses from that. So until next time, I'm going to say goodbye for now. Bye, everybody.